Hello everybody and welcome to another Insight APSAB webinar. My name's Jim Hunt. I'm one of the nurse educators here at Insight and I'd like to welcome everyone for joining us today. Before we begin, I'd like to acknowledge the traditional owners and custodians of the land on which we're meeting today. I'd like to pay my respects to elders past, present and emerging, and I'd like to extend that welcome and respect to any Aboriginal or Torres Strait Islanders that might be joining us out there in webinar land. So welcome and thank you for joining us. Today, I think it's going to be an interesting webinar for clinicians, particularly clinicians that are used to working with clients who are opioid dependent. We've got an Advanced Pharmacist Advisor for Queensland Health, Nicolette Ellis, who's presenting for us on managing persisting pain and opioid prescribing and some of the issues that might arise from that. I should say that Nicolette's also a clinical pharmacist for Beyond Pain, which as far as I can work out, and I'm sure she'll tell us more about this, is kind of a group, an online group of people that are looking at addressing those issues. So without much further ado, I'd like to hand over to Nicolette Ellis, who will tell us about opioids and pain management. So thank you.
And chronic pain issues as well. And so it's an allied health team made of physiotherapists, psychologists, and myself as the pharmacist. And today I just wanted to make sure that all of my views are as an individual profession and they're not the views of Queensland Health. So I'm really pleased to be discussing this conundrum that's coming up in clinical practice around the long-term use of opioid therapy in chronic pain. There's a large population of Australians who take long-term opioid therapy for chronic pain, and we do understand that there are significant harms with these medications, and there's also poor quality evidence in the use of those medicines. In my line of clinical practice, it's very common that I feel very confident and comfortable in the discussions around the use of long-term opioid therapy. And it might seem really logical that we do interventions like opioid tapering, but these are also not without their harms, and we need to have a really pragmatic approach to looking at how we're going to manage these medications with people with complex care needs. So it's not as simple as an opioid tapering plan, and I just wanted to highlight that today with the topic Do Ask, Do Tell, because it's really about facilitating those open discussions and also having or building on that therapeutic relationship so that we have a trusting relationship with our patients as practitioners and health professionals. And we're actually really defining success. So what does success mean? Does it mean a total stopping of all opioids, or is it really more realistic to think about a 10 milligram opioid reduction over a 2 to 3 month period with someone with complex care needs? And that's some questions that we should be really asking ourselves before going into tapering opioids in particular. So today I wanted to give a bit of an overview of what is all this fuss about, and I kind of see opioid articles in the newspaper very frequently, and consumer health organisations showing the same concerns. And we also have this really regulatory scrutiny that is changing prescribing behaviours and pushing prescribers to deprescribe these medicines, and maybe this is causing more harms, and we're not really sure of that yet because we don't have enough research into this area. And one of the things that I find isn't well recognised in practice is the adverse effects of opioids on a long-term basis at high doses. And this can be a really motivating factor for patients in considering, or if they're sitting on the fence about tapering their opioids, if we're screening for these and explaining to them what's actually happening to their system because of the long-term use of opioids. And then I just want to follow up with some really practical approaches that we can look at in putting this into practice, because we do have guidelines around tapering opioids, but guidelines are not tram tracks and they don't apply to complex care needs. So we really need to think about this in a realistic, practical way of how we can achieve better outcomes for our patients. So it's actually Pain Awareness Month in September, and Pain Australia is a fantastic organisation that represents health consumers who live with chronic pain, and they always promote lots of policy and strategy changes in supporting patients with chronic pain. And we've got these painful facts that 3.37% of Australians live with persistent pain, and that's 1 in 5 Australians live with persistent pain. Most of them, or at least half of them, will live with a comorbidity such as depression or anxiety, which increases the complexity of their care needs. And it's very much that GPs will be seeing presentations that involve chronic pain. So at least 20% of their consultations will involve chronic pain. Unfortunately, we only see that 1 in 100 patients receive multidisciplinary care for their complex care needs. And this is because there's lots of barriers to accessing that care. And if I was really cheeky, I could put up the funding that is available for patients with persistent pain. A lot of our consultations also involve medications, and medications unfortunately aren't very effective in persistent pain. And if you look at all of the medications that are available in persistent pain, they're all off-label. So none were ever designed to treat the persistent pain pathology that we know quite a lot about now in today's modern medicine. So there is high quality evidence for opioids in various conditions such as moderate or severe acute pain, opioid dependency, cancer pain, palliative care and end-of-life care. And there's been a considerable increase in the long-term prescribing of opioids for chronic non-cancer pain, but there is ongoing concerns of its effectiveness and safety. But we are in a position where some people's pain will actually be very responsive to opioids for chronic pain. And this may enable them to return back to work and have improved quality of life and function. It is a minority of patients who will have their pain be responsive to opioids, and we know that it has a time-limited benefit for them. But should we be denying people treatment if that means that they can have better quality of life function? And that's the purpose of the medication at the end of the day. Some people, on the other hand, will have real problems with opioids. So will have significant side effects, maybe a risk of overdose, and may turn into an opioid use disorder. So really we need to redefine drug therapies in both the patient minds, but also our mind as well. No analgesic drug unfortunately works well in persistent pain, and we need to really be focusing on that socio-psycho-bio approach. So looking at their functional needs, their functional goals. And when I talk about function, I'm not just talking about movement, I'm talking about their sleep, their mental health, their ability to return to work or volunteer or do things that bring meaning and quality to their life. And again, despite the risks, opioids sometimes remain a necessary option in managing someone's persistent pain presentation. And you will find that patients feel very stigmatized by the use of opioids in their chronic condition. We have a number of clinical guidelines that are available that have been published for a number of years. And it's quite interesting when you look at the evidence of applying this in practice is that we don't really see great uptake of the clinical guidelines in practice. They have made some changes to the levels of opioid prescribing that we have. So the Faculty of Pain Medicine and RACGP and CDC all provide guidelines on what the upper limits or the ceiling dose effect of opioids in chronic pain should be or considered to be prescribed. And the CDC says that we should have caution in prescribing any opioid at any dose in someone with chronic pain and avoiding above 50 milligrams of oral morphine equivalent and particularly above 90 milligrams because we know that there's increased risk with an increase in dose. And they don't seem to be more effective at higher doses. They actually seem to be less effective and cause more consequences to their pain condition. Where we do see lots of changes in prescribing behaviours is unfortunately with regulatory scrutiny. And prescribers' major concern around prescribing opioids is what are the regulatory ramifications of prescribing this medicine. And one of the examples that I experienced as well in practice was when GPs were sent a letter from the Department of Health talking about them being in the 98th percentile of opioid prescribers, which is not a great way to motivate behaviour change in patterns of prescribing. And at the time I was working on the Gold Coast, I was a senior clinical pharmacist for a pain program. We had over 800 prescribers who were referring to our program. We saw a drastic reduction in referrals to our program when this letter was sent out. And we also, just through conversations with GPs, they lost confidence in being able to prescribe the medications and support patients. Of course, this leads to significant harms for patients because we had multiple patients who didn't have GPs, and we had to find a place in their transition of care for a GP who was willing to take on a complex pain case. So this stigmatizes patients and it puts them in a really vulnerable position. We know that if we are omitting or stopping treatment, this is going to cause more harms to the patient at the end of the day. A really fantastic Australian study by Dr. Susie Nielsen, who I believe is coming to do a presentation for Insight, which I'm really looking forward to, is called the POINT cohort study, the Pain and Opioids in Treatment cohort study. And this really highlights how complex this issue is of high dose opioids in particular demographics and patient characteristics. So the pain and opioids treatment cohort study, there was participants who were aged 18 years or older, and they were living with chronic non-cancer pain and taking prescribed Schedule 8 opioids for more than 6 weeks. And they found that the opioid prescribing patterns were really varied within this cohort group. So about 8% of patients were prescribed lower than 20 milligrams of opioid morphine equivalent. About 50% were sitting in that range between 21 and 90 milligrams, which would be reflective of the clinical guidelines. And then over 40% were in the high dose range category. So taking more than 100 milligrams of oral morphine equivalent daily. And when they looked at the patient characteristics and their demographic profiles, they found that these patients had higher rates of unemployment, they had higher mental health problems or comorbidities. There was a correlation with increased rates of childhood abuse or neglect. They had a lifetime of suicide ideation or attempts. They had significant financial constraints, and this was cited as a reason as to a barrier of looking for non-opioid therapies in their chronic pain care. Other findings, most interestingly, was that they actually cited or reported a higher pain levels despite these higher levels of opioids. They were also more likely to be co-prescribed medications like codeine, benzodiazepines, antidepressants, or antipsychotic medications. So this represents a very high risk group with multiple concomitant risk factors for overdose and also multiple barriers to appropriate gold standard care, which is multidisciplinary care. So to me, this is a really complex clinical conundrum that we find ourselves in. We've got this very high risk group with really complex care needs. There's regulatory pressures on GPs and also patients, I believe, around tapering or reducing their medication use. We do have slight poor adoption of clinical guidelines and also application of how we sort of start opioids as well. It's never started as a trial in the literature. It's actually started as a chronic long-term therapy, and we need to be changing our perspective of how we are using these medications and discussing them with patients before we initiate them. So the medication should always be viewed as a trial with measurable benefits, with an exit strategy in mind if we don't achieve those benefits for the patient. So, and again, there's always barriers to multidisciplinary care, especially if you're sitting in a rural or regional area. You're the only GP, there's only one pharmacist, and trying to access these things. But hopefully with COVID, we're getting more flexible with this, with online telehealth consultations and improving access to these sort of things. So there has been one trial about discontinuing chronic opioid therapy, and it was quite startling, the outcomes that occurred in this trial. And they actually found that discontinuing chronic opioid therapy did not reduce the risk of death and was actually associated with an increased risk of overdose. So people who were tapered off opioid medications were 3 times more likely to overdose than someone who was staying on chronic opioid therapy, which is quite startling. There was limitations, obviously, to this study. There was no clarity on how people were tapered, what support they were provided, and also they were lacking referral pathways for people who had emerging opioid use disorder. And so if we're tapering someone and there's an emerging opioid use disorder, we know that they, just my builders in the background, they need early intervention and immediate referral for their complex care needs. So a lot of people might see this trial and say, well, it's more risky if I do taper someone from their opioids, but it is one trial. We need more evidence and more research to see how we can best deal with this in practice. And again, we need to have realistic expectations and a pragmatic approach. So more research is required to understand the risks of tapering chronic opioid therapy. However, stopping access to pharmaceuticals without appropriate treatment and ongoing support of the patient's condition will result in more deaths. And I think we can logically figure that out without having vast research into this area, that if someone is left with no treatment options, they live with chronic pain, they don't have a job, their quality of life is poor, and they don't have any options to be supported or treated, leaves someone in a very desperate and dire condition. So we're often aware of some of the common side effects associated with opioids, such as constipation, sedation, but I find that the long-term effects of opioids are not well recognised in primary care, and it's quite a good way of explaining to patients how these medications may be impacting their pain state or maybe impacting their entire quality of life. And unfortunately, sometimes medications act as a barrier to improving function and quality of life. So there's a number of long-term adverse effects that happen with opioids, including opioid-induced endocrinopathy, osteoporosis, opioid-induced hyperalgesia, and some other less well understood effects on the cardiovascular system and immune system. So if we look at opioid-induced endocrinopathy, we have high density networks of opioid receptors all throughout the body, in the brain, the spinal cord, the peripheral nerves and peripheral tissues like the gastrointestinal tract and immune cells. And we also have them all throughout the HPA axis, if we remember that from our uni days. So the hypothalamus secretes the gonadotropin releasing hormone, which activates our pituitary gland. And this secretes the luteinizing and follicle stimulating hormone. And this hopefully activates our testes if we're a male and our ovaries if we are a female. And this obviously increases our sex hormones, so testosterone, or produces our sex hormones such as testosterone, estrogen, and progesterone. And when we add opioids over a long period of time, and generally at a high dose, we see inhibition both indirectly and directly of the production of sex hormones. So at the HPA axis, there's opioid receptors on all areas, and they reduce gonadotropin releasing hormone, luteinizing and follicle stimulating hormone, and then directly at the sex hormones as well. So without our sex hormones, we aren't functioning very well. And in males, you will see that, and in particular females, you'll see that there is loss of muscle mass or muscle atrophy. And if we're talking about persistent pain, we're usually saying to patients, we need to recondition, we need to get you moving again, do physiotherapy. But how are we able to do this if they actually have muscle atrophy from a long-term medication that they're using? It's not really conducive to improving their function and their abilities to move and be less sedentary. It's also highly linked to causing depression and anxiety, very linked to fatigue. So commonly I see lots of patients who spend most of the days quite heavily sedated and sleeping quite regularly, which disrupts their sleep architecture. And the other thing that's quite interesting about this is that it increases their pain sensitivity. So testosterone in particular, if we have low levels of testosterone, they will have an increase in their pain sensitivity because there is a pathway for testosterone in improving pain perception and pain sensitivity. And I've seen this in young males in their 20s who are at castrate levels on chronic opioid therapy. It's not necessarily the best option to replace testosterone supplementation. It's usually best practice to taper the medication slowly, and testosterone levels usually resolve within a month. For that patient, they feel a lot more improvement in their quality of life and function. I've also seen over the years a number of women with hot flashes or menstrual irregularities who would be my age, not gone through menopause, and some have even been prescribed HRT, which I've found very odd. And this hasn't actually done anything to improve those symptoms. And when I've explained to them what's happened with their body, they're very keen to reduce the medication and get off the HRT therapy and have significant improvements in both their pain experience and that discomfort from those types of symptoms. Obviously, when we have a reduction in sex hormones, we're more at risk of osteoporosis. And this can happen in multiple mechanisms that opioids increase our osteoporosis risk. So obviously it affects the central nervous system, causes sedation and dizziness, and it also can impair the osteoblast activity. So osteoblasts were the little things that go around and make our bone strength and our bone density. And then again, we have the reduction in sex hormones, which are really important for our bone density. So if you have patients who are on long-term high-dose opioid therapy, and this is showing in the research that this can happen even at just 50 milligrams of oral morphine equivalent, it's really important that we are checking and screening their bone mineral density on an annual basis. And opioid-induced hyperalgesia is this well-documented phenomenon, and it's defined as a state of nociceptive sensitization, and it's generally caused by long-term high-dose opioids, but we've seen it with most opioids, including codeine. An interesting fact is buprenorphine is actually an anti-hyperalgesic agent, so the potential for it to increase pain perception or pain sensitivity is very low, and that's because of its unique mechanism. So it's quite a good option if you're screening someone and you're thinking this may be opioid-induced hyperalgesia and you're having difficulty tapering the patient, is to looking at an opioid rotation to buprenorphine if it's appropriate. So how this happens in practice is quite interesting. So there's these microglial cells that sit within the nervous system, and they're types of immune cells. And we thought that they didn't really have much of a function, and they were the scaffolding to holding up the nervous system. But we know in persistent pain that they have quite a significant impact in someone's pain perception. So after long-term high-dose use, opioids will activate these microglial and sort of turn them on. And what they do is they produce the same pain chemicals or pain neurotransmitters that are already happening in the nervous system, and they sensitize the nervous system. So you're getting more input into the nervous system, sending signals to the brain saying that I'm in pain. So some signs and symptoms that this could be happening is that they will have an increased perception of pain with an increase in an opioid dose. And the same goes the other way. If they decrease the opioid dose, they'll see a decrease in their pain experience. Their pain may not be localized to the area anymore. So they might have had lower back pain and it was localized to the lumbar area, but now it's starting to move to the thoracic area or lower legs as well. So their pain's starting to move or spread. It will be generalized, diffuse and ill-defined, and they sometimes present with signs and symptoms like allodynia and also hyperalgesia. So some other effects of opioids is obviously on the cognition and the central nervous system. And I was talking about sedation and over-sedation during the day, which also affects our sleep architecture. And opioids, because of their sedative nature, will stop people from getting down to the deep restful stages of sleep. So this changes our sleep architecture, and then we don't get good quality sleep. And whenever I'm talking to someone who lives with persistent pain, I talk very passionately about the fundamentals of sleep and how important it is to improve someone's pain condition. If we can get sleep right, we usually improve their pain experience. It also can lead to conditions like sleep apnea, or worsen those conditions if they're already present in someone. The gastrointestinal tract is quite interesting, and it's just anecdotally, I've seen a number of patients who have got significant gastroparesis from long-term opioid use. And so much so that when they have had an endoscopy or top and tail, they've found whole opioid tablets in their stomach after all of the pico prep and preparation for their endoscopy and gastroscopy. So it's something that we need to be monitoring, is the effects on the stomach long term. And that was actually a young male who was in his 30s at that time, so a non-functioning immobile gut, and he had lower back pain. And if you think that you've got poor gut function, it usually impacts your lower back as well. Less well understood is the cardiovascular effects. We do have a correlation in increased cardiovascular disease with certain opioids, and probably everyone's very familiar with methadone increasing the QT interval. And also the immune system. So we don't understand the clinical relevance, but we know that some opioids are particularly immunosuppressive, such as fentanyl. I really wanted to spend the rest of today talking about a pragmatic approach to chronic opioid therapy. We know we've got a really high risk group of people who are very vulnerable, and we need to be thinking about, is an opioid tapering plan the best plan for these patients? The guidelines around tapering opioids exist, but they don't exist within the context of people with complex care needs, or even in the context of complex opioid regimes. So they could be on long acting, short acting, they can be on patches, which are very challenging to taper, and also managing those withdrawal effects for patients. And this can cause significant distress. So it's about defining, I guess, success with the patient and trying to get a reasonable outcome. If we're reducing some sort of risk, then we're doing a good job in my experience. So the good news is that 75% of individuals with chronic pain will agree to tapering opioids if offered. And I'm consistently surprised when I am discussing with patients who have been on long-term opioid therapy with no visible benefit, that there's been no discussion around the continued use of these medicines. And they're quite surprised a lot of the time that that's even been offered, because they thought that there's no other option to managing their pain experience. So if we can address these misconceptions that patients might hold with these medications, we usually are a lot more successful. And there's certain patients who will be more easily persuaded or motivated to taper opioids than others. There's those who are younger, dissatisfied with opioids, or have noted no improvement in their function. There's been a lack of response or bothersome side effects. And many patients that I talk to, I ask them, what are the benefits of this medication for you? And they aren't really sure. And if we pose to them, are you interested in re-challenging what the benefits are? They're very usually eager to consider that and look at a tapering plan that's agreed to and a joint decision. There is this 20% of individuals on long-term opioid therapy who will find it incredibly difficult to wean from opioids. And this is generally the category of that very high-risk patient group that I was talking about in that point cohort study. And they'll find that if they reduce or taper the opioid, this may cause distress, psychological distress. It might even increase their pain experience, and they will have a correlating reduction in function. So it is quite a tricky area. And there was this term that kept popping up in the literature called complex persistent dependence. And this comes from the US. I'm not quite very familiar with it, but they're talking about this very complex patient cohort that sits in this gray area. It's very challenging to taper the medications. And sometimes they have signs and symptoms of opioid use disorder, but they don't actually quite fit that category either. So in the US, they are treating people with buprenorphine to taper the medications and get them down to a safer dosage. And they're saying they're finding some success with that, but it's not something that I'm familiar with in practice, this complex persistent dependence, but it's something to sort of think about when we're looking at, is this tapering plan going to work for this particular patient? What are the challenges that we're going to have, or the barriers to access that we will have? So there's certain patient factors and clinical characteristics which can act as barriers to opioid tapering. And individuals with certain personality types will find it difficult to wean from long-term opioid therapy. So those that live with borderline personality disorder tend to be reluctant or resistant to change in treatments, and they have problems with trusting healthcare professionals as well. Individuals with borderline personality disorder have an increased lifetime risk of pharmaceutical dependence, and they also generally are taking other types of medications such as benzodiazepines, or they might have suicidal thoughts or lifetime suicidal thoughts that put them at a higher risk category. And it's important that we are assessing these within the context of the person. If we're approaching about an opioid tapering plan, that this may be more challenging for that patient. I think setting patient expectations, saying that, you know, if you do have depression or anxiety, this may be more challenging for you to taper the opioid, and we might need to consider how we do this. So do we do it over a longer period of time? Do you need more social support, psychological input? All of those sort of things to help support and motivate the patient, and know that they're not going to be abandoned in this process if they're not successful in the mind. It's an intention of success. And sometimes we will have relapses or plateaus that we need to have a stop and a break, and that's very reasonable. Interestingly, people with PTSD, opioid withdrawal symptoms mimic the hypervigilance and startle response of PTSD. And this can really act as a discouragement for patients who live with that condition, and be quite challenging. So I highlighted these particular groups because it's important that we're taking this as information when we're looking at this, and we're not just blindly trying to taper everyone who's on long-term opioid therapy because we feel like we need to de-prescribe these medicines. It's also really important that we understand the views of patients around conversations of chronic opioid therapy, and recognise how patients perceive these conversations. And there are common errors that continue to happen in practice that I see quite regularly, and that show up in all of the literature, is that an opioid tapering plan is just done to someone without their input or even acknowledgement or realisation that it's happening. And that will never be a recipe for success in the end of reducing that. It will probably motivate the patient to seek another prescriber to continue opioid therapy. The other one is that we cite addiction as a reason, or risk of addiction as a reason to reduce an opioid. And that might not apply to most patients. The statistics kind of remain the same around opioid dependence with chronic pain, that it's about 8 to 12% of the population. We don't have a strong statistic to indicate so, but it's not the majority of patients who are on chronic opioid therapy. Most patients that I see and that we do a tapering plan, they're more than capable of living without that medication long term, once they're shown a multimodal approach to their pain management. So a better way to introduce the subject is with the positive benefits, and rather than the negative benefits. And this is really a way to motivate patients to taper opioids for their own personal reasons. And that comes out of your conversation with the patient, what is meaningful to them around this medication. So there might be economic benefits, reducing their pill load. Some are concerned about the stigma that they live with because they get those medications from the pharmacy regularly, or they feel uncomfortable about asking for the medications when they go to see their prescriber. And most patients will be really motivated because it will improve in their pain condition and also their quality of life and function. So it can be quite motivating. And talking to them about those long-term adverse effects that are quite common with long-term use of opioids is quite a motivating factor for a lot of patients, because you're actually answering questions to them of why they're feeling all of these signs and symptoms and why their pain isn't improving despite taking a medication that is supposed to help with pain. It's really important that we also recognise our own views as health practitioners around opioids. Most prescribers are very confident in prescribing opioids for chronic pain, but they have high dissatisfaction in doing that task. Most of the time opioids are prescribed, they are not done within the context of a trial. So they're actually done as a chronic therapy treatment, and they don't have objective outcomes. And this is a mistake that we're making, I think, regularly in the persistent pain world, is that we're not establishing expectations with patients about the use of this medication and what the purpose of this medication is. The purpose is not necessarily to reduce pain, but its purpose is to improve their function. So their quality of life, their movement, and those sort of things. So changing the conversation away from pain intensity to function and quality of life is very beneficial in having these conversations. And one of the most important things we need to discuss with patients is an exit strategy around if this medication is not having measurable benefits. And when I say measurable benefits, we're talking about validating that with validated tools, which we do have. And I'll talk about those in a little bit after this. So the other thing is many prescribers are not very confident or experienced in tapering patients from long-term opioid therapy. And some pharmacists are not confident and experienced in this either. And it is a unique skill that you do start to establish over time and with experience as well, because guidelines are guidelines, they're not tram tracks, and you can't apply the same guidelines to each patient that comes to you. The good news is that health practitioners will see the bulk of patients and probably be the ones who are mainly prescribing opioids, and then the most likely health practitioner to understand the social and psychological impacts, and also the fears or anxieties that they have around tapering opioids. So they really are the best health professional to be helping to support patients with these complex care needs. But I would implore them, general practitioners and prescribers, not to do it solo or feel like they have the burden of doing this heavy lifting, and use allied health teams around them to help support those patients, particularly those ones who are most vulnerable. So for health practitioners, they are really keen to taper opioids because they find it a really dissatisfying practice of chronic opioid use. But they also recognise that this can be a risk to the patient-practitioner relationship. And unfortunately, there will be patients who leave transitions of care because of the attempt to reduce opioids as well. So when I'm talking about opioids and engaging with patients, I actually never start with the medication. I think it's really important when you are thinking about patients who may be at more of the vulnerable category or high risk. If you start talking about the opioid as your initial conversation, that will immediately put barriers up to having a specific discussion around this. So where I start with patients is around how does your condition, your pain affect your day-to-day life, your function, what would you want to be doing that you can't do currently, and how is your current treatment plan facilitating this or improving this, and is it is it doing this or not? So understanding the patient, not the medicine, because we don't want to be thinking about patients as medications. We want to be thinking about understanding the social, psychological and biological contributors that are impacting their day-to-day life. So that's central in establishing if this should be rationalised or tapered, and starting the conversation there. It's really critical also to take some time to understand the purpose or function of the medicine in someone's life before it can be addressed. So there may be some positives and negatives that the patient talks about in the use of that medication, and we need to acknowledge what the positives are for them. And it's a good place to start is talking about the positives. So what do you see as a positive of this medication in your treatment? And they might have all different types of responses, but it gives us an understanding of, you know, what are the benefits for them, and is this actually helping to improve their goals and their functional abilities? Then it's good to talk about what are the risks for them. Have they noticed any of those long-term side effects? And you could do a screening prior to talking about the risks of the medications, and doing an appropriate medication reconciliation assessment. And then, are we doing everything that we possibly can? Have we exhausted all of our alternatives, our self-management strategies? Are there other types of persistent pain, multimodal approaches that we can adopt to try and improve your quality of life? And then posing the question to them of, what if we do nothing at all? So what if we keep you on the same medication regime? We don't change anything. What's going to be an outcome for you? Is this going to be really beneficial at the end of the day? So some of my key things that I talk about when tapering with patients is really talking about the meaningful benefits of tapering to that patient. And a meaningful benefit might be that they have improvement in pain, and they have improvement in function and quality of life, and highlighting that with how the medication may be impacting their ability to function as well. So the personal benefits that are meaningful to them, not, you know, well, it's beneficial because you may be at risk at some point in your life because of addiction with these medications. Preparing the patient, which may take multiple conversations, and making sure that when we're talking about this therapy, it has a measurable purpose. So anytime we're initiating a medication for someone who lives with persistent pain, we should be talking about a goal that they have in mind that they want to achieve, and also how we're going to measure the benefits of that medication. Too often patients are put on medications long-term without actually knowing if it's working or improving their condition, their pain intensity, or their quality of life. Discuss how these outcomes will be measured as well. We've got really good validated tools like the PEG or the brief pain inventory, which are really quick tools that we can use. And we can start a pre and post evaluation, start with a goal in mind, and then measure this over a period of time. And this also might develop some collateral for those patients who may be resilient or resistant to tapering opioids, to show that is there a measurable benefit at the end of the day. And we need to do this over time, you know, over a 3-month sort of period to validate if that medication is beneficial in their care. I can't stress enough how much the plan needs to be mutually agreed upon. There's no way that a patient will be successful if this is just done to them, or if it's not agreed as a plan moving forward. And I don't think it would be safe if we did these things without informing or discussing with the patient and having an agreement, because we need to be talking about how the tapering plan works. So can we tolerate a 10 milligram reduction each week, or does that need to be done over a monthly period or 2 monthly period? So set regular reviews and watch for signs and symptoms of emerging depression, anxiety, mood changes, or suicide ideation. That's really important, especially in that very high risk group category. And evaluate at each dose reduction. So it might seem like this is a lot of work, and it is a lot of work, but use those people around you the allied health teams that can help support these conversations as well. And do regular check-ins. It might be a 10 or 15-minute phone conversation just to see how that patient is going after they've done the reduction. And make sure if they are struggling to plateau the tapering schedule. So one of my largest total morphine equivalents was over 800 OME daily. It was huge. It took us 2.5 years to get that patient down to a 50 milligram OME daily. They did extremely well. They weren't resilient at all to they were actually very keen to reduce the medications. It was a really complex medication regime involving fentanyl, long and short acting opioids as well. And it was when we got down to the lower end of total oral morphine equivalent is when they started struggling. And that was when we paused. We paused for 6 months and then we reviewed, and we were still measuring all of those goals, their functional ability, all of those sorts of things. So this does take time, and there shouldn't be a time frame put on this to achieve success. It should be working with the patient and supporting them. And I know this seems like a lot of work, but I think there's lots of services that are free to patients, including home medicines reviews with accredited pharmacists who are quite advanced in their knowledge in this area. So if you're wanting to start these conversations with patients, it might be a good point to start a referral process to one of accredited pharmacists, and they can actually provide you with a tapering regime and provide you with evidence of that tapering regime. And it's great to show those to patients, to show them that this is not a big scary process. It's actually quite slow and measured, and we'll be supporting you at each step. And there's been changes to home medicines reviews where pharmacists can now do a follow-up review twice after their home medicines review. So it's a great opportunity for GPs to feel more supported in this area and not feel the burden of managing this by themselves. And another plug for pharmacists, because I am one, great utility in having pharmacists within your general practice as well. And there has been changes to the workforce incentive program. So that now allows pharmacists to be part of that workforce incentive program. So that lump sum that you get to have allied health within your team. Unfortunately, it wasn't an increase in funds, but it might be good to look at how you can redistribute some hours and have a pharmacist maybe part-time 1 day a week to help manage these medications in practice and help to support you and ask these questions. And I've found as a pharmacist working with GPs quite regularly that doing this collaborative care approach with both of us really improves the outcomes of supporting and tapering the patient and having success in this and reducing harms for patients. And of course, don't forget about the multidisciplinary pain clinics, addiction services that are there, and screening for those things, and thinking about the patients who probably need additional support and for their complex care needs. This is a website where you can find an accredited pharmacist as well if anyone is looking for it. And I think I've got some questions now, Jim.
You have. Thank you very much indeed, Nicolette. I hope I didn't cut you off too short while we came up to you. We have actually had several questions come in, so thank you very much for everyone who's done that, and please feel free to keep writing them. My colleague Niall is still sat at the computer ready to take any further down. We'll start with something quite basic, I think, but maybe not such a simple answer. When does acute pain become chronic pain, and how do you differentiate between the two?
Yeah, so what we've, the definition is acute pain going to chronic pain is pain continuing for more than 3 to 6 months. There will be different definitions based on the different types of persistent pain to make it even a little bit more confusing. So if they have migraines, there's over 500 types of persistent pain conditions. But if a patient is experiencing pain for more than 3 to 6 months, then we're saying that they are moving into a chronic phase. And they're starting to talk about subacute phase. And no one yet has successfully identified how to treat the subacute phase from acute to chronic. And we know if we do early intervention, we can drastically change the chronicity of the condition as well. So it's an interesting space to watch out. Good question.
And you kind of started answering the next question that I got, because you mentioned in that there are several hundred different types of pain, essentially. And somebody said that we're now getting the understanding that opioids are not good for chronic pain. Is that the case for all chronic pain, or is there some chronic pain in those categories where it may still be useful?
So there's the classifications of different pain conditions. So we have nociceptive pain, nociplastic pain, neuropathic pain, and inflammatory nociceptive pain. So they're a really good start to start having a think about which pain conditions would be responsive to opioids. And usually the nociceptive pain, so conditions like osteoarthritis, where there is a functional reason that there is a pain condition there. But again, when we're thinking about using opioids, we need to, about 60% of patients won't tolerate opioids for a start. And so we need to measure those benefits as a trial period. And generally, I would recommend that you try most things before we go to the opioids, and that's in the guidelines as well. There are conditions where opioids will actually make the pain condition worse, such as neuropathic pain, particularly in patients who are cancer survivors, and they might have neuropathic pain from their cancer treatment as well.
Thank you. Makes sense. Apart from the functional aspects that you mentioned and the balancing of harms, is there any way that we can identify patients who may benefit from the use or indeed may not benefit from the use? In other words, are there any profiles or phenotypes around patients that we can identify who may or may not benefit from opioids?
Oh, that's a really tough one. I don't have a particular answer to that. I think it comes down to, I think we look at the biology a lot of the time, and it's really about, I guess, any time that I'm talking about initiating or recommending a medication to start with a patient, it's about measuring the benefits pre and post. So to my knowledge, I'm not aware of any particular patient characteristics or groups. There's definitely evidence for pain conditions that are more responsive to opioids. But again, we need to do it as an individualized approach. And I know that's not what people want to hear. They want to hear the black and white. But
I think it's life isn't always black and white. And you also mentioned that, in your presentation, some of the patients that may struggle with tapering anyway. And so obviously, if you're putting someone on and they have some of those characteristics already, then that would also, I'd imagine, be something that you'd just be aware of. Somebody's asked, how do you introduce the concept of harms in your discussions with your clients? Because quite often, particularly if they think tapering might be an issue or forthcoming, that they tend to minimise the harms because they don't want things to change.
And I guess that's why I don't start with the medication in my conversations. I start with what is happening in the context of their pain condition and also other conditions which might be contributing to low function, not being able to work, those sort of things. And, it is common that patients will say, oh, actually, it's not that bad, or it's not common, but it does happen in practice that there might be resistance or resilience to around tapering once you've sort of identified and explained to them that this is actually causing more harms. And I look at the side effects of what is happening with the patient and explaining that. And I use a lot of drawings because I'm a visual learner, drawings in practice to discuss those sort of things. And they generally agree, but then they can be quite resilient or resistant to tapering opioids. I don't find it's a majority of patients. I find it's the minority. And then I'd be asking of questions of what else can we do? So let's look at, maybe they're not ready for this conversation yet, and maybe they need to come to the conclusion that it's time, or maybe they may be at risk of opioid use disorder as well. So it's a bit of that grey area.
Some of that resilience is also fear. Get scared
exactly.
of any change, and if we can work towards trying to reduce some of that fear and allow them to know that they have some control over what's going to happen may be useful. So cool. Somebody's asked, can you talk a little bit on fentanyl increasing immune suppression? And is that due to its potency, or is there something else going on with it?
Yeah, so fentanyl and hydromorphone are extremely potent opioids, and we know that people develop tolerance to them really rapidly. So they're medications that I would really try and avoid in persistent pain, unless it's a really, really extreme sort of pain condition and we need a more potent opioid. And we think it's to do with the tolerance, and they're also more, interestingly, more likely to cause things like opioid-induced hyperalgesia. We don't understand the clinical relevance of immunosuppression just yet. So I guess we have to watch that space. But when I was talking about opioid-induced hyperalgesia, I was talking about an immune cell that sort of overreacts and gets very sensitized and increases pain signals. So we know that the persistent pain condition involves the central nervous system and the immune system. They're sort of hand in hand. So it will be interesting to see what the research sort of says around what comes out of obviously, I don't think it could be good suppressing your immune system.
No. And certainly when I'm a mental health nurse, and now they're looking at the immune system being so much involved with mental health conditions as well. So yeah, I think it's also worth pointing out that we are still learning a huge amount about the communication systems within our body and what's going on. So yeah, I don't think we have full answers yet. Somebody's asked, and you kind of already spoke about this with patients that may be finding it difficult to talk about tapering. You mentioned about how promoting sleep is so important in managing pain. And somebody's written in and said, if the client's response is it's the pain that's stopping them sleeping, how would you respond to that?
Yeah, it's a good question, because we know that if we so they did a study of people who didn't live with persistent pain, and they measured their pain threshold, then they sleep deprived them, and then they measured it again, and they basically had no pain threshold. And it is quite common, there's that nexus relationship between pain and poor sleep, because we get microarousals when we're in pain, that disrupts our sleep. So it's difficult to get down to the deep restful stages of sleep. So it would be about looking at how can we manage your pain condition with, it doesn't necessarily need to be opioids. There are other medications that we can use that both help with sleep and a persistent pain condition. And also looking at what's happening under the hood with their sleep, and sleep studies are really important. So 50% of patients who live with persistent pain will have some sort of primary sleep disorder. So it's important that we are making sure that there's not a functional reason. And then looking at how we can better manage their pain condition. A lot of patients, because their function increases through the day, then they find that they're having a flare up at night. So pacing strategies, looking at how they're doing their day-to-day activities and stopping that buildup of discomfort. There's lots of different options that we have to do that, and focusing on some sleep hygiene practices. Yeah.
Cool, thank you very much. And that kind of leads into, I noticed in the UK, there's been a huge increase of late of social prescribing, they call it. The diet, the exercise, good sleep hygiene. Do you see that as something that's likely to grow over here?
Yeah, it's something that, especially at Beyond Pain, that we are driving, is because persistent pain, we have better outcomes with self-management strategies, which is the diet, the exercise, lifestyle changes and modifications. And they are tricky to navigate with patients and show them different ways of managing pain conditions. And it comes down specifically around education of what is happening and what's contributing to your pain condition, because they might just continue to talk about the functional decline or the biological decline that's happening to their joints or system. And we need to have really more of a holistic approach of when we're making strategies or advice for patients.
Couple of questions really about access to resources, I guess. So somebody's asked, do your conversations alter at all if you're working with people in rural and remote areas where perhaps they don't have, maybe the allied health or the, the dietitians, the physiotherapists, whatever it might be. How would your conversation alter that?
I'm lucky, I guess, because I work within a multidisciplinary team. So if we have got barriers or access to care, we can use people within the team if we think it's appropriate for their care. And it is a really challenging area, but there's always something that we can be doing. So quite often within Beyond Pain, we will have conversations with the GP and help to support them in dual conversations. We also have exercise physiologists who are locals in the area who will do joint consultations with to help sort of upskill even those professions there. And we can't forget about, there's loads of online resources that are available to patients as well. So Pain Australia have, I think it's called MindSpot, which is an online education program for directed to patients to learn about and educate them.
You're answering my next question, which is what resources online might be available. So keep coming with it.
And I think we're really changing the dynamics of how we're working in healthcare, because we've got patients with chronic conditions who need access to healthcare, and we're really starting to adopt virtual changes. So there's lots of pain specialists who are now going online. It's good to know who your local pain clinics are as well, and talk to the pain specialists and develop a relationship with them, because they have extensive knowledge of the services that are out there. There's also the community centres are fantastic for hosting things like education about diet, or even doing physiotherapy treatments. They're absolutely fantastic, and they cost really next to nothing.
Getting to know your area is really important, and I think you're right. You know, we know that referrals to pain clinics can mean that you may be waiting for potentially a year, 18 months before you're seen, but that doesn't mean you can't ask them for what resources can I access in the meantime. Yeah, excellent. I guess with the letter that went out and the changes that are coming, is tapering always aiming to come off completely? Somebody else?
Yeah, I think it really bothers me, the regulatory scrutiny around this pressure to deprescribe. And I think we need to look at, as a health profession, as a realistic, this letter was really badly and callously worded, and based off any antibiotic stewardship letter. So, and there was an apology for that as well. So I think really, I don't think people want to see harms from regulation either. And going back to the question, which was...
Sorry, I flipped over my page. Does tapering always mean coming off?
Yeah, and I think that's a really valid point to make, because we know from that study that I showed that there was more harms to patients who came off completely. And the patient that I cited before, who was on 800 milligrams of OME, we maintained him on 50 because he was really functional.
And it's hugely better than what he was on before. Yeah.
And if you've got documentation that you're measuring function, you're talking about goals, you're doing allied healthcare and treatment, I don't think anyone could argue with you that you were doing the wrong thing by your patient and maintaining them on that medication. You're validating the use of the medicine.
And so, as you were saying, it's about that balanced quality of life and everything else included, rather than just focusing on opioids are bad, we must get rid of them.
Yeah, exactly.
Definitely. Somebody's written, so thanks for this one that's just come in. Any thoughts on use of methadone for persistent pain?
Yeah, it's that complex persistent dependence that I was looking at in the literature in the US was interesting. They didn't have a diagnostic tool to say that they have complex persistent dependence. It was just a term that they used, and it was sort of similar to pseudo addiction in some ways. And I think there is utility, and there are some research papers that have come out using buprenorphine or Suboxone in persistent pain. And methadone has a really interesting mechanism of action as well, and works on NMDA, which is part of the persistent pain pathway. And it can be, quite a useful medication. I have seen some pain clinics who are starting to look at the medications that we use for opioid dependency in persistent pain. And I think there is utility there. And if there is a benefit for the patient in improving, maybe that is something that we need to look at in that very high risk group category to hopefully reduce their their total morphine dose, because that is a really high risk, but also continue treatment with something because they're so challenging to taper from those medications. They have extreme withdrawal effects and side effects from it. So I think there is more research that we need to have done in there, and a clear pathway for patients as well. Yeah.
And for those that may not know, NMDA, the glutamate receptor, as opposed to just hitting opioid receptor.
Yeah,
so,
exactly.
It's a more complex pathway.
Yeah.
Kind of the same.
And there is more evidence for the atypical opioids in persistent pain, because they work in different areas. So rather than the morphines and oxycodones who work on one opioid receptor, they see that there's more evidence for the atypical opioids and more benefits, and less likely to cause opioid-induced hyperalgesia and those sort of things. Yeah.
Thank you. I'll probably have this as a last question, because we did have a lot of people writing in. Apologise that we don't get to everybody. Somebody's written in saying that they work in an AOD service, and probably as a result of the concerns that we've talked about around opioids, the letter, etc., that GPs are starting to want to stop prescribing, leaving patients often without prescription, which means that they're coming to the AOD service that now have waiting lists, and it's difficult to manage. The question was actually saying, is there anything that MMU can do to support clients to taper initially, or to at least hold them for a few weeks before they can be picked up by AOD? That's not necessarily a question for you to answer, because you don't work for MMU, but I do know that MMU try very hard to support GPs in that situation, and we have other services such as ADCAS and that, which are useful. But I guess that kind of leads to the question, is there any training, any resources that GPs can access where they can learn about tapering and how to support those clients?
Well, Insight are coming out with some. I'm not sure of the date that will be happening, but we, and I've been helping with some of the writing of opioid tapering for Insight as well. And there's also if you want to look at some resources now that are available for free, the Faculty of Pain Medicine have a fantastic online module about opioids and opioid use in chronic pain, and they talk about tapering opioids as well. I'm more than happy to put up my email as well, if anyone has any questions, specific questions, clinical questions that they want to ask me, because I think we need to support each other in this area as much as possible. There's the CDC guidelines, which will talk about opioid tapering and best practice as well. And I think that's probably the two that I would go with, is the Faculty of Pain Medicine and also the CDC guidelines, and have a review of those. And it's asking colleagues and other people who have experience, especially if you're start with someone that is not so complex and probably on an easier medication regime to sort of find your feet. And when you get to the patients who may be on really high doses of opioids or on complex medication regimes, probably seek some support and advice. A lot of the pain specialists that I speak with, they say they want GPs to call them to ask them these complex questions. They don't want them to do it.
Connections is so important. GPs shouldn't be stopping prescribing without having made some connection, in my opinion. And I would definitely say from the AOD services that I've worked with, they're more than happy to share their knowledge and support the GPs until they're able to bring those people on board. And so, again, we kind of say the same thing, but get to know the services around you and make those links. It will make life better for our clients.
Yeah,
definitely.
And your pharmacists, they're like right next door to you.